And thank you. It's fantastic to be able to sort of double up with Mark and his team just to try and then bring some of the concepts that you've heard as a big picture. What can we actually do in general practice that actually matters? And so that's why this is a safety and quality theme. And you go, well, why is frailty on this topic? Any thoughts? Why would lots of older people with frailty be in a quality and safety stream? Risk. Okay, I wanted to introduce you to the concept of a sentinel event. Now, Mark and his team know what sentinel events are. Who knows what a sentinel event is?
Sorry, is it an event that is a flag waver, if you like, in a situation? So it is the thing that gets you looking at what causes it, what the root cause is.
Yeah, so the big red lights are going, something's happened, catastrophic, probability is often low, but catastrophic effect. And so it means the system must sit up and take notice so that we can look at every possible reasoning why that potentially did occur and what is the system issue behind that happening. So I'm going to bring the concept to you of people in that wonderful age group 75 to 105. We're all on that pathway and that trajectory there. Some of us are a little sooner than others, but the concept of trajectory is really important to understand this. So people turning up at the 75 to 105, turning up to hospital emergency departments. The concept is that that should now be seen as a sentinel event. We need to understand what were the circumstances surrounding that person attending the ED before and the trajectory that got them there and what's going to happen after, because it's a sentinel event because one attendance in an ED for this older person is a risk for two things: another attendance and admission and functional decline. Their trajectory, it's a point in their life where trajectory is on the downward in a big way. So we don't want to see that person in ED again. We want to think about ways that we can actually confront it to help that person keep well at home and look at all the surrounding circumstances of what happened. 30% of all older people, 75 plus, are admitted to hospital because of medication issues. 50% of people 75 plus are on 8 or more medications. 30% of people 75 plus have chronic kidney disease. Usually only 1 in 10 of them know they have it. How many of you here are working in general practice? Majority of you. How well do you think your medical record data is coded for chronic kidney disease? It's pathetic. I know it. And it's something that we all need to do better at. Chronic kidney disease is a major reason for older people getting into big strife with medications, but it's not being recognised. So, we all have a Mrs. Smith in our family. Who has older relatives still alive? Older friends? Okay? This is your family member. I want to make it personal because it matters. Because the system does not look after this group of people. Each of us who have, as we heard from Tracy Johnson, need to have a burning ambition to keep older people well, our family members. Because the system is their enemy. We need to improve a system that actually cares for older people. So that's why I'm going to introduce the concept of frailty, because this is a vulnerable group of people that basically have high care needs, high vulnerability, high complexity, but there is unfortunately low accountability in the system for this group. So look at Mrs. Smith there. Look at all of those jigsaw puzzles up there, the pieces. You know, traditionally, as we heard from Tracy, multi-morbidity is the norm. 50% of people that we see in general practice have at least 2 chronic conditions now. Mrs. Smith has a lot more. She's got lots of providers who don't talk to each other. There's no communication. She has a little bit of cognitive impairment, and she unfortunately can't always tell us. She doesn't have that fantastic assertiveness to actually say, look, doctor, I saw that lovely young doctor in the emergency department and he told me that you needed to do this, this and this. It's never going to happen. So, issues in communication are big errors here. So we need to understand to recognise frailty. I'm going to talk a little bit about some of the things that we need to do that. So, from you as people working in primary care, essentially you need 3 things. Data, good data, to actually find those people who need the care. And again, one of the things that in healthcare error is the right people not getting the right care is a major source of error. You may not see it as an error because most times we see error as something you've done to someone that then ended up in harm. But in this situation, it's actually the right people not getting the right care because you haven't been able to identify the people that most need it. You've been delivering care to all those other people that keep ringing up. That's what general practice is like, isn't it? So, data, you need good tools as clinicians to be able to identify frailty, and we need the right attitude. And one of the things about the right attitude, a little secret is, we know about healthy ageing, is that we do not respond to older people going, sorry darling, you're just getting older, nothing we can do. That is the wrong response. That is a response that would lead to harm for that older person because you have failed to recognise risk. But you've also failed to recognise there are so many things that you can do differently to work with that older person, work with them, goal setting, review, thinking about all the issues, identifying all of their concerns that can actually help keep them well and safe at home. The beach study. Tracy mentioned this a little bit earlier, I believe, but and there was the beach room she went to. It's the beach study, looks at general practice in Australia every year. Essentially, 2012, I think, was this set of data I sort of grabbed. If you're 85 and you are female, you go to the GP on average 16 times a year. And if you're male, you go 19 times, believe it or not. Older blokes go more often. It's on average. So they are in our surgeries, consulting rooms, a lot of the time every year. Are we doing the right job? So, what is the right job? Health assessments. How many of you actually do health assessments for older people? Okay, yep. Really important. Why are they so important? Oh, good. I'm glad that you didn't say it. It's because it earns a shitload of money for practice. Because that could be the cynical way of looking at it, couldn't it? All right. Do we know they are done well? Main purpose, underlined, to prevent further decline in function. Really important aspect here. Low take-up in Australia. Less than 20% of older people have had a health assessment. Is there evidence for impact? The lovely Professor Gill at Deakin University says no. There is no evidence for the impact of health assessments. Now, I'm going to make a little disclaimer on this because it's very, I've had discussions about this. Number one, are the templates that we use fit for purpose to actually do the job that's required to make the impact? We have to think about what health assessments are. In the geriatrician world, the comprehensive geriatric assessment is what has evidence for making a difference to keep people well, looking at all the geriatric syndromes to understand what's going on. What is in our medical software? Who uses Medical Director? Okay, somebody. It's a rubbish template for health assessments. Why? Because it does not have objective tools for assessing the need of older people. It has a little tick box, doesn't it? There aren't a whole lot of tools. A mini-mental, yes. It has a geriatric depression scale, yes. They're about the only tools that are actually in there. So there's also a whole lot of evidence that barriers for older people to come and see you or to actually have health assessments done by you at home. They don't see any value in it. There was a great study released by Karen Grimmer from the University of South Australia last year that focus groups of older people have had health assessments under the MBS. They all basically said, this delivered no value to me as an older person to help keep me well and safe at home. Now, isn't that an absolute travesty? How much MBS money is going to do something that older people see no value? And the clinicians that were actually involved also didn't think it did a lot. So although there was, I think, gentleman at the back, your name? Ben. Yeah, so you believe they do a good job, so I'm glad that you're with us on that. So you saw this morning, Kaiser Permanente pyramid. So clearly with Tracy Johnson this morning, you actually have to know this backwards. You need to understand the data in your practice to know who is at level 1 and 2. These are the most vulnerable, crucial people. You've got to find them and know who they are intimately. And you saw from the Medibank private crew that that's the crew they want to work on. Why? Keep them out of hospital, care at home is safe, keeping them well out of aged care facilities, and having the right supports. That's what we're going to do. But you know what happens? This bit here, the level 4 people, they're the majority that get health assessments in this country. They're the 80-year-olds that are out playing golf, going on Mediterranean cruises. They want their podiatry. I want it now because I am one of the population that says I can get free stuff from you and the government. The people up the top here, they're vulnerable. They have hearing issues, eye issues, cognition issues. They're not banging your door down saying, I want and need. They need your advocacy as nurses. So we've got to find them. So going back to your tools, it's about, we're going to get 3 things that make a difference to this group: data, tools, and attitude. Okay, so numbers are big, but do you know in your practice? So look at that, 20% of 80-year-olds in your practice will have frailty. 10 practices in Adelaide I'm working with. Again, how many of you actually are data queens or kings in your practices that actually know how to use your pencat, can actually print this off if I came and had a chat to you next week? 2 or 3 of you. Okay, your role, if you listen to Tracy from this morning, you've got to know this stuff backwards because no one else in your practice is even going to bother. If you're going to be advocates for older people in our community, you have to know this. So basically what this is showing, in these practices, that's how many people 75, that's their total active population, that's a percent. So some of these practices, 23% people 75 and over, huge. Some are 6%, that's my practice there. So actually we only have a small percentage, have big numbers. So that's how many frail people by definition actually are in there. So we've got 280. Do we know all those? I'm working on it. We need a registry. Okay, so I'm just going to skip over some of this. Because I want to get the concept of frailty. Okay, here's a very fit, well, we're on this trajectory. All of us are on this trajectory. So I don't think it's just someone else, all of us. Fit, well, managing well, vulnerable, frail, and all its different, and then there's the end. Now, that's nice and linear. Now, here we go. Here's basically Linda Freed. She's a geriatrician and epidemiologist from the US. It might be Canada, but very well published concepts of frailty in older people. Again, concepts of healthy ageing, going well, loss of capacity, vulnerability. Here's this trajectory you need to think about. Down we're going. Something happens. Acute loss of capacity and acute illness. Now in frailty, that could be as simple as a UTI. Could be as simple as an upper respiratory tract infection. Could be as simple as a fall. Could be as simple as a change of medication. And bang, they're down. And then, yep, you get a bit of recovery, but it's never the same. So what is this thing called frailty? Really important part. How many would you actually know about frailty? Okay, really important. In the geriatrician world, this is their bread and butter. But the rest of the hospital sector doesn't know, and general practice, primary care, don't know much about it either. So, really important that we actually get our heads around it. So, if we've got people in our practice that have got weight loss, low grip strength, exhaustion, low physical activity, and low walking speed. That's the cluster. That's frailty. It's a long-term condition. This does not get better, but we can make a difference to improve it. Now, I'm running a 90-minute workshop on all this in the afternoon if you're interested in knowing a whole heap more detail, because this is critical stuff to what we're going to be doing. So why do we get frailty? This is a nice little definition here. So basically it's characterised by that older person having decreased reserve and resilience to withstand everyday things that happen. And diminished resistance to the things that stress them out, stress physically their system. And it can also be mental stress as well. But it's all related to this big problem called sarcopenia. Who's familiar with sarcopenia? Loss of muscle mass as we all get older. And so that's a really important part, and I won't bore you with the really complex slide on why, but as we all get older, we all lose muscle mass. And basically, this is actually the best picture, because here we are 25-year-old cells, the Murphys of the world of APNA that have, essentially lots of muscle. And then look what happens. This is a healthy 75-year-old. Looking a bit sad. The number of muscle cells didn't actually change. The actual size of those cells, and a bit of muscle death as well, but the size of those cells, and importantly, the mitochondria quality changed markedly. So that's a really important thing to think about. Okay, so basically it develops slowly, and it has a whole lot of other impacts as far as the immunosenescence. Who went to Rayna's session on immunisation yesterday? Yep, so we're talking about immunosenescence, changes in our own immune system after the age of, she said 50. That's when we're all on that decline. So lucky us. Okay, now, really important. So this is a tool for you all when you are seeing your older person. Gait speed as an important clinical indicator. Who measures gait speed for their older people in their health assessments? You do. Fantastic. One over there. Do I see a hand? Anyway, give me hope. Okay, anyway, as of Monday, you'll all be measuring walking speed, because in this age group, vital sign. So we all do blood pressures. Why? Why do we do blood pressures? Pardon?
Check that it's not too high.
Yeah, but why do you worry? Yeah, exactly. Okay, so walking speed in this age group, in the essentially the 75 plus, your long-term future is completely dependent upon your walking speed and not your blood pressure. So why measure the blood pressures if the walking speed is slow? Really important point here. So there's a whole lot of evidence on this, but it's unfortunately not getting out there. Okay, this is a really important one too. Measurement of physical activity. Grip strength is linked, and basically the pluses mean lots of positive studies, E's mean equivocal, and minuses mean there's absolutely no evidence of an association between. So again, it's an area, it's still a grey area. It's, we haven't got everything supportive evidence, but we need to think about it. Grip strength linked to fractures, cognitive decline, cardiovascular disease. Walking speed. You can see, linked, that's a really important one, linked to all these things. Your ability to get out of the chair. You visualise that when you see the person in the waiting room getting up and out of the chair. You're already seeing it, but are you doing anything about it when you do that care plan for diabetes for 80-year-old Mrs. Smith? No, you're just worrying about the HbA1c that's 6.5%. You're doing a single disease care plan for a person who has 7 or 8 conditions. You're missing the point if you do not pick this up. The diabetes does not matter. Standing balance, really important. So, why worry? All these issues. This is what happens with the clinical syndrome of frailty. Adverse outcomes are huge. This is why people go to hospital and get admitted. And in hospital, they lie around. Even if you're lying around for 12 hours in an ED, you are deconditioning those already fraught skeletal muscles. Risk. This is what happens then. We would basically need to encourage our older people to really get with it and exercise, build those muscles, resistance training. Now, look at those. These are at least 5 kilo weights. That's a 40 kilo lift. I reckon there's probably only a few of us in the room that would be able to do that. It's possible to build muscle even at 80. So don't go just because you're getting old. All right, tool. Okay, data, use PenCat. Who uses PenCat? Great. Here's a recipe for finding your at-risk people. Essentially using this, and it's about 8 or more medications, diagnosis of chronic kidney disease. So if you haven't got it coding, you're missing out. It's worth money. Heart failure, COPD, depression, stroke, dementia. These are the big factors that are not necessarily the cause, but this cluster puts people at risk. Now, develop this idea of report card. What's my population of 75 plus? Now, unfortunately, our software, and we're dependent upon poor software in this country, does not help delineate between if you're an aged care facility resident or a community dwelling 75-year-old. And I'm focusing on the community dwelling first up. Anyway, that's by the by. Who's had a health assessment? The percentage of people aged 75 plus taking 8 or more medications. Who's having annual HMRs? And who's had their BMI checked within the 6 months? This group of people should have their weight checked every single consultation. Otherwise, you'll miss the people losing weight. Okay, so is your template up to scratch? I know I've got only a little bit of time left. How many of you doing the health assessments also do the care plan for that older person? Only a third of those. You can do it the same visit. It's all legal. So it's a really good opportunity because you have knowledge. You want to make those recommendations stick. The biggest problem with recommendations and health assessments is that often the doctors don't even look at them. They don't act on them. And all that great work you've done has been missed out. And if you are the nurse doing the health assessment and there's someone else doing the care plan for diabetes and heart disease, they never even get to see your work. The two are completely not linked. Risk, error, problem, hospital admission. We can do something about it. Okay, so what we've got to incorporate is some tools. Essentially, there are many tools, but this is my favourite because it's easy, simple. Because one of the really important things about doing a great quality job that's safe is make the right thing easy to do. So, John Morley, geriatrician, St. Louis in the US, has got the Frail screen, evidence-based. It's been validated multiple times. There's 300 screening tools. So let's just stick with something that's simple, that's been validated. F-R-A-I-L, the word frail. And it's conversational. Are you feeling fatigued? Resistance means can you get your body weight, the weight of your body, can you take gravity's resistance up a flight of stairs? A for ambulation, can you walk around the block? And I for 5 or more illnesses, and that loss of weight is really important. Scoring 2 at risk, 3 referral onwards. Doesn't mean you just need 5 visits to podiatry, does it? Now, this afternoon I will go into a lot more, all the referral options for you. But think about your aged care providers. Think about exercise. Okay, who's got a dynamometer in their practice? No, exactly. And the geriatricians have challenged me. Why, Chris, do GPs and practice nurses not have this? I said, how much is this wonderful thing here? They're about $1,000. So I said, cynically, there's no item number for that. But, as you saw before, there's a whole lot of evidence about keeping people well. So my challenge was, let's go and find one. $25 on eBay. All right, that one's a bit more, but digital, set the age. If you're a man at 75, yes?
What was it called, sorry?
A dynamometer. Measures force, grip strength. Okay, so essentially 30 kilos for a man at 75, 20 for a female. Okay, walking speed. So we talked a bit about that. So taking more than 5 seconds to walk 4 metres predicts your future big systemic review. How do you do it? Okay, so in your practices, if you're going to do it, or in the person's home, you take either 3 cones. You've got to have an acceleration zone because, remember, our older people with Parkinson's, what happens with Parkinson's? Paucity of movement, slow initiation. So get ready, set, go. Okay, so, all right, now I want you to get to that line and then the stopwatch will start, okay? All right, we get going. All right, and then the stopwatch goes off and then the deceleration. Your iPhone has a stopwatch, so measure, really important tool. Timed up and go, who's familiar with this? Timed up and go, the person sits in the chair, so it's looking at basically being able to get up out of the chair, walk 3 metres, if you put a cone or a little spot, walk that 3 metres, get back in that chair. So if they complete it in less than 10 seconds, they're basically good, but let's look at preventing falls or the other issues that you would always do when you're in their homes. More than 10 seconds, huge falls risk. Red light goes on. We must put in place prevention. Okay, geriatric depression scale, you all know about. Mini nutritional assessments. Who knows this? Okay, so many of the 75% talk a little bit about assessing, but undernutrition in this age group is a major reason for frailty. Sometimes it's the consequences of frailty, sometimes it's a leader. So the web is linked together. Now, little secret, who's got an iPhone here? Great, you can get this on an app. Make it easy to do. I'll show you. Okay, so screening, and it's a screening tool. Okay, so I want you to, same with the frail script. It screens, it helps you identify. Your job's not done once you've screened. You've actually got to then do something else after that. So screening's the first bit, raising your awareness, using the screening tool, and then bringing it to everyone's attention. It's a bit like what Mark said. Captain, we've got a problem. Chris is frail. He's at risk of going into hospital and major decline. We've got to do something. So that's really important. Okay, so the MNA looks at all these things that are really important in a person's life. It's pretty straightforward. It's those questions, but this is the important part. Look this up, get this on your iPhone, use it when you see people in their homes and in the surgery. And even better, okay, there's a training video on YouTube. Okay, so this is really good. So it's a really important tool. All right, now this is something the lovely named Professor John Young. He's a community geriatrician. That's what the play on words, young and geriatrician. That in Nottingham in the UK. This is what happens currently. The frail elderly, presenting latent crisis, hospital-based, disruptive, disjointed, all that Mrs. Smith stuff, crisis. This is where we all need to go. And this is what medical homes are about. We actually care enough to think about people before the shit happens. Okay? You are advocates for these people. We need to coordinate their care. We need to anticipate because they are vulnerable. You are smart clinicians. You know older people. That trajectory, you can all anticipate that stuff happens along the trajectory. So just like diabetes, let's look at it as a long-term condition, timely identification, prevention, proactive care, self-management, personalised care planning. We need to own this in general practice. You, as nurses doing a fantastic job in your communities, need to be able to own this. It's not about geriatricians locked up in hospitals doing it. Okay, so your care planning approach, what are the most important things you want to discuss today? What's limiting your mobility? What's limiting the things? A really good entree question is, what matters most to you? Not what's the matter with you, what matters most to you? What gives you joy in your life? And what's preventing you getting that joy anymore? Goal-centred patient approaches is what we need to be doing. Not, right, we've got to get your HbA1c down below 7, your blood pressure down below 140. We've got to get, all those things that we see on care plans. This needs to be patient-centred. All right, British Geriatric Society work hugely with the English College of GPs. There's something called Fit for Frailty, which is their Bible in the UK for nurses in primary care, anyone working with older people. So Fit for Frailty, Google it, there's a great PDF of this. But look, avoid hospital, limit the iatrogenic problems. Mark mentioned those issues about what we do in healthcare causes major issues, polypharmacy, wrong care, not enough care for the right people, all that sort of stuff. Anticipate. We need to actually make sure that we've got an individualised care plan. It's linked to this optimisation. What's optimisation mean? Yeah, so most people think it's about their disease. How can I get my disease better? Chronic disease doesn't get better. How can we actually make sure that keeping people well, how to improve function at this age group is what our goals must be. That's what it's about. How to keep people well at home. What do they need to do that? Escalation plan. What's that mean?
Being prepared to escalate to increase your efforts.
Yeah. So, asthma action plans, COPD action plans, who does them? That's an escalation plan. Things start going a little bit pear-shaped. Let's do something. Increase this, do that. Things get really bad. We've got to do that. That's what the crisis plan is, the urgent plan. Med reviews, of course, and advanced care directives. Okay, I've done social history. So that's what we need to look at, the frail screen. FRAIL, commit that to memory, take that home with you. That's one of the most important tools in your materium that you can use for that next older person's health assessment. But your attitude, it's not just about getting older and nothing can be done. Your burning ambition is to help keep this person well at home, living independently. Thank you.